when we how we define the labor, when there is a regular painful uterine contraction occur, and this lead to the change in the effacement of the cervix and the descent of the presenting part. As a result, there is an expulsion of the fetus and placenta occur. The mechanism underlying this labor is still not known, but there are certain factors that are responsible, and there are certain hormonal changes that are responsible for causing the mechanism of the labor. As we all know that the progesterone is responsible for coiting the uterus. It keeps the uterus coit, but during the termination, during the labor, this progesterone receptors they decrease, and there is an increase in estrogen receptors, and the mechanism behind this is still not known, but there are certain other changes that are also occurs. There is a as we know that because of the increase in estrogen, this cause increase in prostaglandin, and prostaglandin cause the uterine muscles contraction, and when near labor, near when the labor starts, the prostaglandin is increased. Estrogen cause increase in prostaglandin synthesis. This prostaglandin is also produced by chorion as well as deciduous, and they cause increase in contraction of the uterine muscles that lead to the process to start. And certain changes also occurs from the fetal adrenal gland. There is a release of cortisol, and from the fetus there is a release of oxytocin as well. This all factors lead to the increase in lead to the uterine contraction. Plus, once the labor started, there is a Ferguson reflex occurs that cause that the presenting part, this cause the stretching of the cervix, and because of the stretching of the cervix, Ferguson reflex occurs. There is a sensation goes on the spinal cord, from there goes in the higher side, from the posterior pituitary, cause the release of the oxytocin, and this will lead to the initiation of the process of labor. Now, as you all know that myometrium composed of outer longitudinal muscle fiber, middle crisscross fiber, and inner circular fibers. And the function of these fibers, they cause the contraction and retraction, relaxation, and then retraction. With each contraction, after contraction, there is then relaxation occurs, and then retraction of the lower segment. And this contraction then spread in all directions as compared to the skeletal muscle, which acts only along its axis. It produces gradual retraction and shortening of the muscle fibers. All this special feature of the myometrium is brought about by the influx of the calcium ion. This calcium bind to the calmodulin calcium binding protein. This calmodulin in turn bind to the active myosin light chain kinase enzyme. This activation of calcium ion and increase of intracellular cytosol calcium concentration. This calcium then promote contraction. Cyclic AMP promote contraction, while CGMP promote relaxation. Now there are certain definitions which you all must have knowledge about this definition. What is lie? Lie is the relationship between the long axis of the fetus and the long axis of the mother. And this lie can be longitudinal lie, which is present mostly in 99% cases. But this can be transverse lie as well. Now the presentation. What is the presentation? It is the portion of the fetus which is overlying the pelvic inlet. This is known as presentation. Presentation in 95% cases, presentation is cephalic presentation, but presentation can be breached. Baby can be presented with breech presentation when the head lie in the fundus and the breech is in the inlet. Other presentation which occurs in 4% cases are compound presentation, that is more than one presenting part is present in the inlet. What is position? Position is the relationship between the reference point on the presenting fetal part and maternal bony pelvis. If we subcategorize this, direct occipito-inferior is the most common at delivery at cephalic presentation. Other occipito-inferior positions are right occipito-inferior, left occipito-inferior, occipito-posterior position, right occipito-posterior position, left occipito-posterior position. What is attitude? It is the degree of flexion or extension of the head. If the head is well flexed, then it will be presented by cephalic presentation. Partial extension will lead to the brow presentation, and full and hyperextended fetus will be presented by face presentation. So these are the different types of the presentation, and this include in attitude. Station. Station is the degree of descent through the presenting part. Station is the degree of the descent through the presenting part through the birth canal. It expressed in centimeter. The presenting part is above or below the maternal ischial spine. If it is 1 centimeter above the ischial spine, we said that the head is above 1 centimeter above the ischial spine. This presentation varies with the descent of the presenting part during the stage of the labor. If it is prior to the engagement of the head, it will be at -4 position, means -4 centimeter above the ischial spine. Sphincterism is the orientation of the fetal sagittal suture to the midline between maternal pelvis and sacral promontory. This may be anterior or posterior. There might be anterior or posterior ascentilism. Now, if we see the different type of pelvis that is present, there are 4 type of the pelvis which is present, but the most common type of the pelvis and which is responsible for normal delivery is gynecoid type of the pelvis. This gynecoid type of the pelvis is shaped like a round. It is round in shape. It is good for normal vaginal delivery. But in anthropoid type of the pelvis is long and oval. It is also good for vaginal delivery, but android type of the pelvis is heart shaped. It is a short pelvis. The anterior posterior diameter is small and it is poor. It will not help in normal delivery. In such type of the women who have android type of the pelvis, they will end up in cesarean section. Or platyploid type of the pelvis, these are flat and oval. These are short type of the pelvis. Again, it will not favor the normal delivery. Now, these are the, during the mechanism of the labor, there are certain movements that that occur during the whole process of the labor. And these movements are known as cardinal movements of the labor. And these are 7 in number. And first and the most important movement is engagement. What is an engagement? Engagement is when the greatest part of the baby head passes the inlet of the pelvis. Means if we examine from the abdomen, then 2/5 part of the head of the baby is palpable above the inlet. After sorry, after engagement, there is a descent of the head. In the descent of the head in the pelvic cavity, and this descent, after descent there is a flexion, and this flexion occurs because of the pelvic muscle, and the pelvic muscles that favor the flexion and internal rotation is levator ani muscle. After flexion, there is internal rotation occurs. Why there is internal rotation occur? Internal rotation occur in order to in order to help to the head to pass through the pelvic outlet. So the smallest, because of this internal rotation, the smallest diameter of the fetal head comes through the pelvic outlet. After internal rotation, there is extension occur. Extension occur when the fetal head pass through the pelvic outlet and it pass the pelvic outlet, and at this time there is a crowning occur. We said that the crowning of the fetus occurs. So during extension, crowning is the process that is occurring. After extension, there is restitution occur. What happens that the head moves slightly in the direction of the shoulder when it come out of the vulva. And after restitution, there is external rotation occur. During external rotation, there is alignment of the head and shoulder, and head pass out of the pelvic outlet. And after external rotation, there is delivery of the baby. So these are the 7 cardinal movements that are important and is going on during the process of labor. How we manage the labor? uh, how the management of the labor. First, in order to manage the labor, first of all, we have to diagnose that the labor is begin or not, and how we diagnose it by the help of the palpation of the abdomen, so that we will be able to palpate the uterine contraction by doing the vaginal examination. This will help in assessing the dilatation of the cervix, length of the cervix, presentation of the fetal part, and the distance of the fetal part from the ischial spine, and the labor is diagnosed by the presence of show. What is show? It is a mucus plug along with blood, or sometimes patient present with rupture of the membrane. Normally, if we goes on labors, labor is divided in 3 stages: first stage, second stage, and third stage. What is the first stage? First stage is that it is from the start of the labor till full dilatation of the labor, that full dilatation of the cervix, that is about 10 centimeter. And again, this first stage is divided in 2 parts: latent phase and active phase. What is the latent phase? Latent phase is the time interval up to 3 to 4 centimeters. And during this phase, there is a cervical dilatation. Any effacement occurs when the cervix becomes 3 to 4 centimeters dilated. There is effacement of the cervix. In primary gravida, first effacement occurs, then dilatation. In multigravida, both effacement and dilatation occur at the same time. Now, the second part of the first stage is active phase. This active phase starts from 3 to 4 centimeter till full dilatation. Now, if the patient came in first stage of labor, how we manage? Examine of the patient, examination of the general condition of the patient, pulse, BP, per abdominal examination, per vaginal examination. During vaginal examination, we see the presentation, position, condition of the membrane, whether it is intact or whether it is ruptured, dilatation of the cervix. We assure the patient, give the enema, shave the presenting part. If patient any desire to bear down should be discouraged, because if they start pushing before the full dilatation, it will cause the tearing of the cervix. Now, how the first stage of labor manage the patient complaint of pain, then we can give them a buscopan, pethidine, morphine. We take the bladder care and assess the progress of the labor. and start making the partogram after 3 to 4 centimeter when the cervix becomes 3 to 4 centimeter dilated when we start making the partogram. These are the graphical recording of the labor. How we manage the second stage of the labor? Second stage of the labor is defined when the from the full dilatation of the cervix to the delivery of the fetus. This is known as second stage. Again, second stage is divided in two parts, passive phase and active phase. Passive phase is the time interval between full dilatation and the onset of expulsive involuntary uterine expulsive in contraction. Now the active phase. This is the active phase is when the patient has the urge to push. Patient want to push the baby out. This is known as active phase. How we manage the second stage of the labor? Second stage of labor should be managed by keep the patient in bed. A nurse or doctor should stay with her. Position of the patient should be made either left lateral, dorsal, either position patient want, we make the position of the patient. Bladder should be empty. Thigh and perineum covered with the sterile towel. Clean the perineum with the iodine solution and observe the perineum with each contraction and watch whether crowning occurs or not. What is crowning? When the presenting part is protruding from the vulva and it will not go back with when the contraction is ceased. We will give the episiotomy if required. When we give the episiotomy, episiotomy should be given at the time of crowning. And then delivery of the head should be done by the help of the support of by the nurse or the companion. Once the head delivered, we will give the ergometry in order to in order to prevent the relaxation of the uterus. Then the delivery of the shoulder. After delivery of the shoulder, delivery of the baby. After delivery of the baby, immediate care of the child. And the anesthesia that can be given in the second stage is nitrous oxide or oxygen mixture plus oxygen mixture. Now this is the drawing showing the different cardinal movement, which I already told. This engagement, now then the descent during the pelvic cavity, and then flexion of the baby head. This picture shows the internal rotation. This picture shows the extension, then restitution. This is restitution, head come out, then this is an external rotation, alignment of the shoulder and the head. During third stage of labor, what we do in third stage of the labor, care after the delivery of the baby, care of the child, whip out the secretion from the mouth by means of the suction of the nasopharynx and the mouth, care of the mother, delivery of the placenta, examination of the placenta, look for any tear or laceration in the perineum and watch for PPH. This third stage of labor again, delivery of the placenta. This delivery of the placenta included in third stage of labor. Normally the duration of third stage of labor is 10 to 20 seconds, but sometimes it extends more than 30 seconds. The delivery of the placenta can be by means of active management or by means of passive management. What is an active management of the third stage of labor? Active management of third stage of labor is When the placenta sign of placental separation is seen, that is the blood is seen coming out, we put one hand above the pubic symphysis in order to push the uterus above upward, and from the other hand we made a controlled contraction. This helps in the delivery of the placenta. This is known as the active method of delivery of the placenta. Sometimes when there is no comorbidity present, patient want passive method. Passive method when we do not give any uterotonic drug or anything, but this lead to the excessive bleeding. So normally we perform the active management of third stage of labor in order to deliver the placenta. After delivery of the placenta, we examine the placenta and the membrane, whether it is complete, incomplete, number of the cotyledons, is there any cotyledon of the placenta missing, marginal blood vessel, look for any hole or tear which is present in the placenta. Separate the chorion and amnion we separate them. Examine of the perineum. Then we examine the perineum of the patient if there is any tear or is there any excessive bleeding is present. Watch for the bleeding. If whether patient is normally bleed or there is more than normal bleeding. If there is more than normal bleeding, then we manage this accordingly. Give the uterotonic drugs, and this help in closure of the sinuses and decrease the bleeding. So, is there any question? Is there any question from anyone? वकान साहब कोई पूछ नहीं रहा कुछ क्वेश्चन? क्या आपने इनको अनम्यूट नहीं किया है?
मैम मैं अनम्यूट कर देता हूँ इनको, ठीक है।
मैं जो लेक्चर लेने के बाद वही सवाल पूछती हूँ।
नहीं अम्मा, दूसरा वाला है चार्जर आईफोन का। पापा तो नहीं ले गया। मैं इतना बुरा मना रहा था कि क्यों ऐसे लड़ाई करते हैं।